Okay, this video is iron and diabetes, the effect of excess body iron on diabetes. This is part 7 of the iron overload lectures. So what is it that damages the pancreas? We talked about insulin resistance before, especially from saturated fat, but it's also increased and made worse with excessive dietary sodium, deficiency of potassium, deficiency of magnesium. Omega-6 oils increase the risk of pancreas failure, so to speak, the beta cells of the pancreas. Hereditary hemochromatosis leads to what's called bronze diabetes, where the skin is also bronzed. So iron overload does contribute to injury of pancreas beta cells. Iron overloaded humans have increased rates of diabetes. High serum ferritins will be associated with increased risk of diabetes. You know, there's several ways that it could contribute to this. It could be from oxidative stress contributing to it. Let me get into some of the papers here in just a moment. We've seen some of these before. I've given multiple lectures on diabetes. I have an entire playlist of lectures on diabetes. Probably the most important thing to know is that excessive dietary fat intake, especially saturated fat, it just overwhelms the plasma membrane of the skeletal muscle cells, and it gets in, and then it starts to cause insulin resistance within the mitochondria. It's a flip-flop maneuver of entry into the skeletal muscle cells. Okay, and then there's a progressive accumulation of fat in locations where it does not belong. So normally fat should be stored in your belly in the saturated fat, not in the visceral compartment, for example. And that can help you survive the winter or brief phases of starvation. But the problem occurs when fat starts accumulating in skeletal muscle. That'll cause postprandial after eating, insulin resistance. The fat will accumulate in the liver. That'll cause fasting insulin resistance, leading to hyperglycemia during fasting. And eventually it accumulates in the pancreas, and that'll cause injury to the pancreas beta cells, the ones that make insulin, and that'll cause pancreas failure. And when you can't make insulin, then you become insulin dependent, so that's more advanced diabetes. These are just some of the complications over here. Okay, elevated serum ferritin is associated with increased insulin resistance, and there's a component of it that's just due to you're going to have higher iron levels if you eat a lot of meat, and persons who eat a lot of meat have more fat and more insulin resistance. But there's also a component that's independent of that. Okay, you have increased risk of ferroptosis, cell death, due to a combination of excess iron as well as lipid peroxidation. Okay, increased ferritin level will, another paper just, saying something similar. Increased ferritin is associated with increased insulin resistance. Increased serum ferritin is also associated with increased obesity, insulin resistance, hyperglycemia, and increased blood triglycerides. Okay, this guy, Leo Zacharski, he did a lot of excellent research to figure out what should be the desirable serum ferritin level. And it's probably, the bottom end, some people say you get below 25, you're at increased risk for restless legs. So some people have a problem with that. Some people say just being below 100 is good. In the perfect world, you'd ideally like your serum ferritin between about 25 to 80. And you want to know that because you're going to check your serum ferritin to decide if you should donate blood or not, and how much blood you should donate or how often you should do it. So that's important to know. A desirable serum ferritin, sort of a perfect serum ferritin would be between 25 to 80. There's some papers that even recommend keeping it below 50, 25 to 50. Okay. By the way, mine was 240 because I used to eat all those iron-containing cereals. I didn't know any better. And then I donated some blood, and I watched my diet real carefully. And now my most recent one is 140, and I think I'm going to get it down real rapid from there. What I've been doing is, if I donate blood, not donate blood, if I just go for a blood test, total cholesterol, vitamin B12 or something, I'll have them pull off a couple extra tubes, and I'm working my way down. I want to get it, below 80 eventually is my goal. My total cholesterol is great, like 90 to 120, so I'm pretty comfortable with that. Okay, these are just more papers showing that iron also excess free iron is prothrombotic. It distorts the shape of the red blood cell. We showed that in recent lectures on what it does to the blood. It also distorts the shape of fibrinogen, the clotting protein, so it predisposes the blood to thrombosis. All these things, diabetes causes a lot of problems that predispose to thrombosis, and simultaneous elevated iron is bad because you get more of an abnormal clot, the dense matted deposits because of the distorted fibrinogen transitioning from beta-pleated sheet, normal anatomic shape for it from an alpha helix cylindrical shape into a beta-pleated sheet, a flattened shape, which can stack upon itself to form oligomers and polymers of fibrinogen. So the clots are more irregular, they're harder to dissolve, more prone to becoming occlusive and blocking an artery to the Johnson, to the heart, to the brain. So it's all bad. That's the main reason people die, is plugged up arteries. And the brain is a stroke, and the heart is a heart attack. Okay, this is just showing the picture. You've seen this a lot of times. Outer mitochondrial membrane, OMM. Inner mitochondrial membrane, IMM. Inner mitochondrial membrane is where electron transport occurs. This is how, the vast majority of energy is made in the human body. All right, and it's just passed like a fireman bucket brigade from complex 1 to coenzyme Q to complex 3 to complex 4, and then the electrons handed off to oxygen, the ultimate electron acceptor, that gets converted into water. Once in a while, some of these electrons will leak to the oxygen in the mitochondrial matrix, and that'll be made into superoxide. Superoxide is a free radical, has an unpaired electron in its outer orbital, but the mitochondria is ready for that. This happens on a routine basis. It has superoxide dismutase, and it just converts it into water, and it ends up being no big deal. The problem is going to be when there's excess iron, because that can take this in a different direction and make it into free radical hydroxyl radicals. And all of that is part of the oxidative stress. Now here's something relatively unique to diabetes, the formation of all these advanced glycation end products. In particular, because you've inhibited electron transport, you get a backup of Krebs cycle and you get a backup of glycolysis. And this is the key enzyme that's inhibited, glyceraldehyde 3-phosphate dehydrogenase. And because that's inhibited, the substrate for its reaction accumulates, glyceraldehyde 3-phosphate. And then it starts getting activated through separate pathways, and it gets made into this methyl glyoxal, often abbreviated MGO. And that goes all over the place, causing advanced glycation end products. In particular, you can see, for example, let's say just glucose in the blood, or fructose in the blood can do this too. They open and close in different ring configurations, and while they're in the open form, they can glycate proteins like hemoglobin A1C, with hemoglobin being glycated. So this is just showing when it's in the open configuration, glucose, for example. I'm now talking about something different than the methyl glyoxal. I'm just getting to the idea of advanced glycation end products and diabetes. They'll come from three directions. Number one, they can come from the meat and other high protein, high fat foods that you eat. Number two, they can come from hyperglycemia in the blood. And number three, they can come from the reversal of electron transport, leading to backup of Krebs cycle and glycolysis with the subsequent conversion of glyceraldehyde 3-phosphate into the MGO. So those are three major ways that you're going to form advanced glycation end products with diabetes. And this is all going to be relevant in a second. I'm going to show how this all comes together. So in diabetes, you not only glycate hemoglobin, you glycate the blood iron transport protein, transferrin. When transferrin is glycated, it cannot hold as much iron. Same thing when you glycate ferritin, that's the primarily intracellular iron storage molecule. When that's glycated, it also cannot hang on to iron as well, because glycation changes the shape of the protein, and so it can no longer do its job as effectively. So the more NTBI, non-transferrin bound iron, you have, the more problems you have. Transferrin, the iron transport protein, also binds to chromium. So when you distort the transferrin shape by binding to iron, you also decrease its ability to bind chromium. Normally, transferrin delivers chromium to cells, which is needed for optimal insulin sensitivity. So this loss of chromium is another contributing factor in iron overload, leading to insulin resistance. Okay, here's more of an extensive diagram showing the advanced glycation end products unique to diabetes insulin resistance, whereby the glyceraldehyde 3-phosphate is converted to MGO, methyl glyoxal. The methyl glyoxal will exit the cell and start to glycate the extracellular matrix proteins. That's bad. It'll exit the cell and glycate things like albumin. It'll glycate hemoglobin to make your hemoglobin A1C go up, and it'll cause generalized inflammation. We won't go through all the details of this. I talk about all this in great length in my diabetes lectures, but I'm just making the point that you get a lot more advanced glycation end products in diabetes. And then it damages TF as transferrin. The glycated transferrin starts leaking iron. You can't hang on as tight, so you get more non-transferrin bound iron. The non-transferrin bound iron will undergo the Fenton reaction to produce hydroxyl radicals, damaging pancreatic beta cells and a lot of other things, including red blood cell plasma membranes. If you've got omega-6 fats around and you're producing reactive oxygens and you're undergoing lipid peroxidation, you'll be getting ferroptosis, which is going to damage cells. Ferroptosis is death due to excess iron, especially in combination with lipid peroxidation, which especially occurs with excess omega-6 fat intake, for example. Okay, other problems, we talked about the transferrin protein being damaged by glycation, leading to not being able to transport chromium so well. The CR is for chromium, and that's going to contribute to insulin resistance because it can't deliver the chromium to the cells, so they're more vulnerable to becoming insulin resistant. The increased free iron in the blood due to the transferrin's inability to adequately sequester it and bind to it is going to cause increased reactivation of dormant bacteria in the blood. So in a sense, it's a form of immune suppression. The bacteria are becoming activated because the iron is not adequately kept away from them. Bacteria need iron to grow, and dormant bacteria in the blood, when iron becomes present, will become reactivated. So you're basically heading down this iatrogenic cascade of problems. Diabetes causes thickening of the capillary basement membrane, in part from the advanced glycation end products. Also, hypertension will cause hypertrophy of the vascular smooth muscle cells. So here's a normal capillary, red blood cells traveling through, and these blue circles are the oxygen being delivered to the tissues. With the diabetic and a hypertensive diabetic, the diabetic's going to have thickened capillary basement membrane. Hypertensive is also going to have hypertrophied vascular smooth muscle cells. And these together contribute to making oxygen less able to pass from the red blood cell to the tissue. So you're going to have more tissue hypoxia. That's not good. Every cell functions better when it has optimal oxygen delivery. So you're going to have a lot of problems here. You're going to have insulin resistance, leading to less glucose availability for hippocampal neurons in the brain's memory center. They're also going to have decreased oxygen available because of the thickened capillary basement membrane and the hypertrophied vascular smooth muscle cells. Okay, also in the brain, they used to think it didn't get insulin resistance, but now we know that it is sensitive to that because while you've got glucose type 1 transporters at the blood-brain barrier and glucose type 3 glucose transporters in the neurons, in addition to that, you have glucose type 4 transporters. And it's the glucose type 4 transporters that are that require insulin for them to open up and will really be transported to the plasma membrane and fuse with it so glucose can come in. So you're not going to be able to get glucose into the hippocampal neurons as effectively as normally because you have insulin resistance. Okay, so what I'm kind of pointing to, and I go into this in much more detail in my lectures on diabetes and dementia, but I'm just showing you iron is adding to this stacking group of problems that are going to contribute to neurodegeneration and make people demented. You know, like I said, I've had my internal medicine friends tell me all their patients over 60 are cognitively impaired. And iron is a contributor to this. Iron also contributes to dementia in different ways and to being hyperthrombotic, and we're going to discuss those in the lectures soon to come. So that's it. Hope it was helpful.